Good morning, everyone. Thank you for inviting me to spend the morning with you all and getting our day going. So we'll be talking about febrile seizures today, and just a little bit about what definition of febrile seizures, the different types, and when to be concerned, and just some counseling that you can provide to the patients in a primary care setting, as well as when to refer the patients to neurology. All right, so febrile seizure is defined as, well, it's the most common form of childhood seizure. It occurs in about 2 to 5% in the US and in Western Europe. In Asia, in some of the Asian population, the prevalence is a bit higher, 8 to 10%. And it's defined as a seizure that is associated with a fever or a febrile illness that is not caused by a central nervous system infection. The patient cannot have a prior unprovoked seizure, and it's not due to other acute symptomatic seizures, for example, like a TBI or a tumor, some other acute causes. And contrary to traditional beliefs, most patients don't have a fever at the time of their seizure. Only about 21% of a febrile seizure patient experienced a fever within 1 hour of their febrile seizure. And more than half of those febrile seizures have a fever occurrence within the 24-hour. And about a quarter of febrile seizures, the patients have a fever, even after 24 hours. So the rule of thumb is that we said that febrile seizures is a seizure that's associated with a fever within the 24-hour period of the seizure. The age range is interesting because the definition, most of the research and organizations agree on the definition, but the age range is a little bit, there's some discrepancy there. And the International League Against Epilepsy in 1993 defined that febrile seizures can occur as young as 1 month of age, whereas the American Academy of Pediatrics, the NIH, and the UK groups define febrile seizures at the onset of 6 months of age. We do see about 10% of febrile seizures occur before 6 months of age. The peak of occurrence is about 18 to 24 months of age, particularly if the child is within that age range in a seasonal period of the winter months where common colds and viruses are being passed around. We're in close proximity indoors. So daycare children at that age are very prone to febrile seizures. And 90% of the febrile seizure occurrences are before 3 years of age. So that's when we see febrile seizures sort of kind of dwindling down and resolve closer to 4 to 6 years of age. We do have some outliers who still have febrile seizures. It's to the upper limit of 6 to 8 years of age. And so in practice, we, see febrile seizures. Age duration is between 6 months and 6 years of age. I think that's a good range to keep in mind. And I didn't put here, but most of the children are neurologically normal and don't have any other developmental delays, any other issues. We believe that febrile seizures are familial. So about 25 to 40% of children with febrile seizures have a family history of febrile seizures. And it's a couple of different things: environmental, epigenetics, and all those things play a role. And we think it's a little bit of an aberrant developmental component of the brain during that age time frame. But majority of febrile seizures patients are normal, healthy, and they outgrow them. So febrile seizures are divided into three types. You have simple febrile seizures, complex febrile seizure, and febrile status epilepticus. Now, and it's based on the duration. Simple febrile seizures, we say 10 to 15 minutes, shorter than 10 to 15 minutes. And I know watching a child seize for 10 to 15 minutes sounds like, and it feels like an eternity, but 15 minutes is what we consider as a febrile seizure, the simple. If it's greater than 15 minutes, then it becomes complex. And febrile status is purely based on duration. So longer than 30 minutes of a seizure is considered febrile status epilepticus. Or if a child has had multiple brief seizures that add up to about 30 minutes and they don't recover in between those seizures. Onset. So the onset of the seizure semiology. Simple febrile seizure patients generally have generalized convulsive type of seizures, the general tonic-clonic ones, or generalized tonic seizures. Whereas the complex febrile seizure patients often have focal onset, one arm or one leg, and it generalizes, or it recurs within a 24-hour period, whereas the simple febrile seizure patients do not have more than one brief seizure within a 24-hour period. The other component is any neurological deficits. Patients with simple febrile seizures are usually back to baseline very quickly without any deficits, whereas sometimes complex febrile seizures could have things like ATAS paralysis, or changes in their mental status. Takes a little bit longer to recover back to their baseline. Most febrile seizures are simple febrile seizures. About 20 to 30% of all febrile seizures are complex, and less than 5% of the febrile seizures are febrile status epilepticus. The patients that we are concerned about, or we get that we watch a little more closely and maybe do a little bit more evaluation, are the patients with the complex febrile seizures, particularly because they have a higher chance of developing epilepsy later on, and because of the focality. Many of them may require imaging. And of course, the febrile status epilepticus, so really prolonged seizures. And we can talk about that a little bit more in the next few slides. So the initial assessment is a very good history and physical exam to make sure that patients who had a febrile seizure has, the seizure stopped, they've returned back to baseline, they're not in a prolonged post-ictal phase. A good rule of thumb is that when the eyes close, that means that the seizures probably stopped. Their responsiveness, pinching their fingers or so, and if they respond to pain, that's a good indication that the seizure has stopped. And finding and treating the cause of the fever with the febrile illness is really important, because febrile seizures is actually a symptom of many diagnoses. It's not the diagnosis itself. So looking for the cause of the fever is really important. And we always want to make sure that the patients who present with complex febrile seizure or febrile status, that there's no concerns for a serious, infection like a CNS infection. Now, MRIs and EEGs and imaging and some of those other tests that we sometimes use to evaluate febrile seizures are not commonly recommended, because usually they're all normal. However, in a subset of patients that we do recommend workup include the ones that have focal onset of their seizure, if they have febrile status epilepticus, or their neurologic examination is abnormal. So I think this is the important part for most, what you see in primary care and what we see in our office as well, because, the ER doctors and the hospitalists take care of the acute management. But for us in outpatient care, assessing their risks and their post-acute management counseling is really important for caregivers and families. So the big questions are, can this occur? And yes, it can occur. And unfortunately, the younger the age of onset, the higher the higher the risk for febrile seizure to recur. And remember, particularly if they are in this age range, in those winter months, febrile seizures tend to recur, and they can go up to about 70% of recurrence. Is this epilepsy, or will it become epilepsy? It's also important to differentiate epilepsy from febrile seizures. And so patients with febrile seizures have less than 5% chance of developing epilepsy in the future. And most of those are the ones who have complex febrile seizures. So other risk factors that contribute to developing epilepsy later in life are developmental delays. If the patient has an abnormal neurologic examination, like a patient who has subtle cerebral palsy, they may have had, previous, insult or brain injury or things like that, that makes them more vulnerable or have risk factors that are not yet apparent. And also a first degree relative with epilepsy. So those are the risk factors to keep in mind when you're counseling families about developing epilepsy later in life. And does this cause brain damage? So we get this question a lot from families, 10 to 15-minute seizure, that's a long time. There are a few retrospective studies looking at, prolonged seizures. And unfortunately, there is a small subset of patients who develop mesotemporal sclerosis after febrile status, but that's still pretty low as well. So this is something that's not common, and we don't see this too often. And believe it or not, the risk of developmental delays, behavior or academic difficulties in children with febrile seizure is no greater than the general population. So that's really important to keep in mind as well when you're counseling patients. And what can caregivers do to stop the febrile seizure next time it occurs? Because the younger the age, the higher the risk of recurrence. So it's really important to evaluate and treat the febrile illness. So that's why we ask the families to see their primary care doctors to make sure that there's no serious infection and get that under control. Using antipyretics are helpful, but for comfort, but it does not prevent a febrile seizure. Unfortunately, we do recommend caregivers to treat the fever, but it does not prevent febrile seizures. In some occasions, we have used intermittent benzodiazepines, some long-acting benzodiazepine to sort of raise threshold for seizures when we know that a patient has a pattern, or the ones who has multiple febrile seizures within a 24-hour period. We sometimes give benzodiazepine when they're sick in that peak 24 to 48 hours. There has been some studies that show that it reduces hospitalizations and parent anxiety and things like that, but it does not impact long-term outcome of febrile seizures. And then rescue. So we recommend that patients get a rescue medication if they have a febrile seizure that does not stop within 5 minutes. And there's a handful of different types of rescue medications now that are benzodiazepine that you can give intranasally, buccal, as well as rectally as well. And you may have seen us prescribe a number of those types of rescue medications. And which patients are the ones you should refer to neurology? And that's the last question, is which we've been talking about. Those are the complex febrile seizure patients, the patients who have febrile status, patients who have developmental delays. The younger age we often see, and we think we should see them so that, some of these patients have other epilepsy syndromes that manifest, about it's called Dravet syndrome. And these are the patients who present around 1 year of age with repeated, hemiclonic febrile seizures. So if they're younger, we definitely recommend referral. And if there's an abnormal neurological examination, any focal findings on their examination, or any history of any other neurological, any kind of dysmorphism and things like that, because those patients may not be febrile seizures, and they may be, other types of epilepsy that is just unmasked by the febrile illness. And that's it. I wanted to keep it short so that we can have time to, for you to ask specific questions and be on time. So I'm open for questions if anyone has any.
I do have a question.
Yes.
So what do you recommend as far as the parents obviously want to know, should they be giving Tylenol or an ibuprofen and alternating during the entire course of illness? And I'm not sure exactly what to tell parents as far as like when to stop, how long to go?
Yes, yes. So, well, giving Tylenol and Motrin only helps with comfort, treating the fever so the child's not so cranky and they're unhappy and uncomfortable. But it doesn't prevent them from having febrile seizures. We generally tell them that most febrile seizures occur within the 24 to 48 hours of the febrile illness. And so I would say you can probably recommend, it's safe to recommend up to a 48-hour of alternating Motrin and Tylenol. And sometimes we even extend it to 72 hours. Those really stubborn viral, like the HHV6 and HHV7, those can provoke fever for a longer duration. So I think 48 to 72 hours of alternating Motrin and Tylenol to keep the temperature, lower so the patients are comfortable, that's reasonable to recommend.
Thank you.
Should we be prescribing like a Diastat or something?
Yes, you are able to prescribe Diastat. Diastat is FDA approved for children 6 months and older. Unfortunately, the little ones can't have Diastat. And if you go to the Diastat website, there's a nice little handy chart that tells you the weight and the age and the dosage that you should prescribe. We always err on we want you to round up, because one of the reasons why seizures don't stop is an underdosing of the rescue medication. So we would recommend that you prescribe the Diastat for patients 6 months and older, and using that chart on the website. When they are older, 6 years and older, we can use the intranasal diazepam, but by then most patients with febrile seizures have resolved. They stop having febrile seizures. The other option that we recommend using is a dissolvable clonazepam, where you put it inside a child's cheek and it dissolves. And that dosing is also,
Just went to Diastat.
so, but we usually recommend having that for cluster seizures, or if they have seizures that recur, and those complex febrile seizure patients who have recurrence of those seizures within 24-hour period, you can give that as well to prevent them from having more febrile seizures. But short answer is yes, you can prescribe Diastat.
But only for like a 24, 48-hour period, or?
You mean like how often can you use Diastat?
Yeah.
Yes, you can use Diastats. Actually, you can use up to 2 doses at one time. When you prescribe Diastat, the kit comes with 2 doses. So the parent can give the first dose of the rectal gel, and if the seizure doesn't stop within 5 minutes, they're allowed to give a second dose as well. And if they have to give a second dose and the seizure is still going or hasn't stopped, you're approaching, pretty long seizure, and they should be calling 911.
Okay, thank you.
But just to clarify,
Yes.
we're not prescribing this for everybody. It's only if they've had if they have a complex one that's going longer than 15 minutes. Correct?
Yes.
So a lot of them that we're seeing in follow-up, maybe they lasted a minute, maybe 2, and if it's anything longer than that, it's because the parent didn't time it. So we don't have to be sending Diastat home with everybody, correct?
That is correct. Yes. So we prescribe Diastat if they present with a febrile seizure that's longer than 5 minutes, then they would need a rescue medicine.
Okay.
And if they have complex, meaning they have had more than one seizure in the 24-hour period, then you would prescribe them a Diastat rescue.
Is Diastat pretty expensive, or is it pretty much covered over the years since it's been out for a while?
Believe it or not, it is still expensive, and some Medicaids do not cover it unless you have a diagnosis of epilepsy. And so we sometimes have to write, letters of medical necessities to their insurance. In general, I would say it's pretty widely covered. Just a few Medicaids that don't cover Diastat.
Okay, thank you.
I did, just a quick question. I did have a special case where this kid had recurrent febrile seizures, and I did prescribe Diastat because he was having it for 17 minutes, was the longest. He'd been seen neurology prior and everything was clear. Is he a case that I did say, let's go back to neurology, because I didn't like, they kept getting longer and longer. Is this something that's common that you see too, and then they still outgrow it?
Yes, so, those febrile seizure durations can vary. They can have a simple one, they can have one that's 2 minutes, one time, and then they have another one that's 15 minutes. So it just depends. And not to say anything about parents, but the duration is always overestimated, or it always feels like an eternity, watching a child have a seizure. But it doesn't mean that they won't outgrow it. If the patient is like completely neurologically intact and normal, and there's no other red flags, and no family history of epilepsy, you can still reassure the family that, yes, we expect the patient to outgrow their febrile seizure closer to around 4 years of age.
Perfect. Thank you. I appreciate that.
Yeah. A lot of this is counseling and really, anticipatory guidance to the families, because those are the common questions that we get asked to in our clinic.
Yeah, absolutely. Thank you.
Yeah, no problem. Any other question? Well, we're happy to, see these patients. The simple febrile seizure probably don't need referral, and but giving a family a rescue plan, or some directions how to treat their child, when to call, and when to be concerned, are probably the really important advice to give them in the acute. And we often see complex febrile seizures and febrile status, and believe it or not, sometimes these patients have other things going on. So those are the ones that should be referred to neurology, and we're happy to evaluate them. And you can get my contact from Carisha if you have any more questions. Definitely feel free to reach out if you have any additional questions. So thank you very much.